we have this problem that older diabetic folk come into hospital hypo and it gets misdiagnosed as other things, as strokes, TIAs, fits, waterworks infections. You know, there's a bit of muck in the wee, so therefore they have a UTI rather than a hypo. And it is a bit of a worry. So there's this hypoglycemia unawareness amongst the professionals. So the professionals report spotting hypos, and it occurs amongst the patients as well. So the level at which older folk get the sympathetic symptoms of sweatiness and shakiness occurs at very much the same sort of level, about 3 millimoles is the level at which they get neuroglycopenic, muddled and fall over. So hypoglycemic unawareness in patients and in staff is a real problem. And when older folk do go hypo and do notice they've gone hypo, 20% of the time when you ask, they will deny it. So it's really important to grill family and carers about funny, sweaty, shaky muddle turns. Now, those are the common features, the common symptoms of hypoglycemia, sweaty, shaky muddle turns. But these are some other symptoms, and in particular, unsteadiness and lightheadedness. If you give older folk long-acting insulin analogues, then they tend to go low just before breakfast. They hop out of bed with a low blood sugar, and they're unsteady and lightheaded. So you think, well, that's the blood pressure tablets. So it's really important in our diabetic patients, if they get any funny turns whatsoever on insulin or sulfonylureas, that you consider hypoglycemia and that you test the blood sugar if possible. And the symptoms change over the years. The patients say, I can't be a hypo, it's different. But no, the hypoglycemia symptoms will change over the years. Now, how common are hypos? So this is an awful slide of a brilliant study by Dr. Munshi, and all she did was put continuous glucose monitors on about 33 people for 3.5 days, and lo and behold, 20 of them went hypo. There were 77 hypos, of which 3 were symptomatic. Or in English, hypoglycemia is extremely common. It's often unrecognised. It's predominantly unrecognised. It's often in the middle of the night. And it happens in folk with high HbA1cs. If you look at folk in Medicare and Kaiser Permanente data, the people that go hypo are the people with the low HbA1cs and the high HbA1cs. So I have a low threshold in folk who are having difficulty with glucose control on insulin and testing a blood glucose in the middle of the night, or rather getting them to test it in the middle of the night. So all these hypos, do they matter? And there's a lot of observational data showing a link between diabetes, hypoglycemia and dementia. So quite a few studies have shown that if you become hypo in late middle life, that increases your risk of dementia as the years go by. But on the other hand, if you're getting demented, then you're probably going to go hypo. And a nice little observational study by Yafke just took a lot of older folk in clinic who were well and followed them up. And if they had a hypo as the first event, then that doubled their risk of future dementia. And if they got dementia, that trebled their risk of future hypoglycemia. So there's a very, very close interrelationship between hypoglycemia and dementia in the diabetic folk. But the message is we want to avoid the hypos because of the possible cognitive impairment. And hypos do much more than make you a bit muddled. There's fairly good data now, fairly good sort of observational data showing that hypos and low blood HbA1c levels are associated with falls, fractures, permanent neurological loss. They increase your QT interval on the ECG. They give you ischemic changes on the ECG. They make you die, and you give you a long stay in hospital. And otherwise, hypos are quite innocuous. So, who's going to go hypo? And it's any failure, any comorbidity, that increases the risk of hypoglycemia. So if you're thinking of giving someone metformin, but you say, no, they've got a bit of heart failure or liver impairment, which aren't contraindications to metformin. I've got a bit of heart failure, a bit of liver impairment, I'm going to give them a sulfonylurea. They're at increased risk of hypos. So any comorbidity, elderly single males, probably because they're not too good at getting their food, I guess. Alcohol, that's a risk factor for hypoglycemia, cognitive impairment and increasing age. But the killer risk factor is hospitalisation. So when folk come into hospital for whatever reason, then in the 6 or 12 weeks after discharge, they're at increased risk of hypoglycemia. So in these folk, it's really important that when we're discharging folk from hospital on insulin or sulfonylurea, someone, doesn't matter who, someone looks at them at 4 to 6 weeks after discharge to screen for hypos. It can be the district nurse, the diabetic nurse in the general practice, the GP, hospital doctor, whoever. It doesn't matter so long as it's done. And the other thing one wants to do is ensure an adequate diet. And it's difficult in hospitals getting hold of diet sheets, but there are two great resources. So the first one is the Nutrition Advisory Group for Elderly People, which is a subgroup of the British Dietetic Association. They make fantastic big A4 leaflets on what to eat. And that's great for the older person. But actually, if you get a new type 1 diabetic person coming in the middle of the night and you're just trying to get them home quickly, this is good as a sort of a quick and dirty fix. And the other thing is, if you have a multi-ethnic population like we do with multiple languages, Diabetes UK website has a diet guide in many, many different languages. So we've recently used Somalian, Polish and Portuguese. So someone's gone hypo. What are the things I consider? The first thing is, we used to think that gliclazide was quite short-acting, and it's better than glibenclamide. Most things are. But you can still keep going hypo 5 days after the last dose of gliclazide. Has the person lost weight? Do they need less treatment? Have they developed renal impairment? Are their drugs building up? And are they on the best treatment? If they're on insulin, is it the best insulin for them? Do they really need it? If they're on a sulfonylurea, is it a safer sulfonylurea such as tolbutamide? Do they need the SU? We'd look at the injection technique, and that can be quite educational. We think our patients are doing fine, and when you get them to actually inject in front of you, they can make a pig's ear of it. Chasing sugars. I'm sure you've all seen this. The blood sugar's high, so they increase the insulin, and then they go hypo, so they drop the insulin dose, and then they go high, so they're just yo-yoing. So in folk like that, you need to drop the insulin dose, leave them to run a bit high for a while, and then crank the dose up. We've discussed nighttime hypos. Be very suspicious of those. It's taken me 20 years. I have now found someone whose hypos were due to Addison's disease. So things like Addison's disease will give you hypos, but you might spend a little while trying to find it. ACE inhibitors. Data from Scotland and Holland shows that ACE inhibitors increase the risk of hypos, and angiotensin receptor blockers don't. So I tend to switch to ARBs. We've discussed alcohol and chasing inappropriately low HbA1c targets. So on the subject of glucose targets, I prefer the ADA EASD 2012 guidance. And what it says is that actually most of your patients would probably not fit in any of the clinical trials that were done. So as long as you know what you're doing, you can do what you like. We quite like that, actually. And they say, you could go for really hacking down the sugars in folk that, that folk that were keen to do it. If you're not going to poison them off, so if you're using a gliptin rather than a sulfonylurea, you can go for lower targets. If it's short duration of diabetes, you've got more to gain given the legacy effect. If they're going to live a while rather than just a few months, you could really go and tighten things down. So it's looking at the patient and looking at your treatment. So if your treatments are relatively harmless and you know what you're doing and the patient's relatively fit and up for it, then you can drive down the HbA1c. And Professor Sinclair's guidance would be for about 7-ish%, whereas if you've got someone that's frail, multiple comorbidities, you're doing something dangerous, then something like 8 and a bit% would be a sensible target. And you see the targets are all HbA1c based, and the government, with whatever it is, says you've got to measure the HbA1c. But do we think they know what they're doing? Well, of course they don't, because the A1c can be unreliable. So it increases with aging. It changes with ethnicity. So people with Afro-Caribbean origin have a 0.5% rise in their A1c. If you become anemic due to lack of iron or B12, you'll raise your HbA1c. We've had folk come in hypoglycemia on gliclazide, which is being used to treat their iron deficiency anemia. So you've got to look at the blood count. And also, if you have significant CKD, the A1C gets very unreliable with an EGFR under 20, and it's an average. So if you've got someone who's going low in the middle of the night and high in the morning, their A1C can be to target. And if the target on the government guidance is under 6%, then clearly 4 or 5% is to target, but they will be going hyper if on a sulfonylurea or insulin, and you will be harming them. So that's targets. Well, I come from Bristol, and lots of folk in Bristol do drugs, so we better go on to drugs. Here we go then. Metformin. Dead keen on metformin. You don't get hypos, doesn't put the weight on. There's some papers coming out now that show it might not be as dangerous in renal impairment as we think, but I think it's watch this space, because the risk with renal impairment is lactic acidosis, and whether the diagnosis is actually made in these population studies correctly or not, I would just be a little bit careful. So it's care in renal impairment. It can cause dramatic weight loss. It doubles the risk of vitamin B12 deficiency, and you're all aware of the dramatic diarrhea folk get on the metformin. That's metformin. The pioglitazone is really the only TZD we might use. You don't get hypos. It might be good for fatty liver. It's vascular protective in the proactive study. And the catch with pio is people get swollen legs and they get bigger and bigger. And if you don't look for it, you will miss it. And some folk get anemic on it. The weight gain is a problem. And 10-year data suggests that bladder cancer is not a problem with pio. But with the weight gain and the edema, we tend to use less pio now than before. So we are very much into gliptins, and we very much buy into gliptins. They drop the A1C as much as any other drug. We think they're safe, and not only do we think they're safe, the FDA and the EMEA think they're safe, and they keep reviewing the safety of gliptins and GLP-1 RAs like liraglutide. You don't get hypos, you don't get weight gain, and I think the main side effect is a skin rash, and if you get a skin rash on one gliptin, you'll get a skin rash on the other. Do they do any good? And this is a meta-analysis of all the gliptin trials, and it shows that if you give people gliptins, 42,000 folk on the gliptin, then the chance of a major adverse cardiovascular event or heart attack or stroke or mortality goes down. So it looks like they might be vascular protective. That's sort of multiple RCT data. This is real-world data from the UK, GP database. You've got someone on metformin. Do you want to give them a sulfonylurea or do you want to give them a gliptin? So Dr. Curry and co. Took folk and they matched folk on metformin plus SU to metformin plus gliptin. And this is the death rate. So there were nearly twice as many deaths on the sulfonylurea as on the gliptin, and there were more heart attacks and strokes on the SU than on the gliptin. So there's data here from the RCT meta-analyses and from observational data in the UK that gliptins might actually decrease vascular events, and that's a high chance of what will kill our diabetic folk. Now, we're really bothered by hypos, and there's a reason to suspect that gliptins and GLP-1s might decrease the hypo rate on insulin and sulfonylureas. And in this study here, folk got randomized who are on insulin got randomized to having a placebo or linagliptin, and when you added in the linagliptin, then the A1C goes down. That's good. We're paying 30 quid a month for that. So what happens to the hypo rate? Well, oddly enough, the hypo rate goes down. If you have someone on insulin and you drop the A1C, you will routinely put the hypo rate up. But this is the converse. You put the hypo rate down. That's just one study, and a review of all the gliptin added to insulin studies concluded that actually when you add a gliptin to insulin, you drop the HbA1c, but you don't increase the hypo rate. So this is a really handy trick in your difficult diabetic folk or the diabetic folk with difficult diabetes. So the gliptins, they've all got very similar indications now. They've all got very different routes of excretion and actually all very different molecules. So we want to wait 10 years to see the full set of side effects, but they do seem safe-ish. And the gliptins, I think, really are a good drug for older folk because of their safety. You don't get the peripheral edema that you get with Pio, you don't get the hypos you get with an SU. So the new ones on the block are the SGLT2 inhibitors, so we're quite intrigued by these, and I think the adverts are quite good because what these things do is they just make you pee out sugar. So peeing out the sugar, it gives you an A1C reduction the same as any other tablet of about 0.6%. You lose weight because you're losing calories, so you lose weight, you lose as much as liraglutide. And it drops your blood pressure because as well as peeing out sugar, you're peeing out salt. And you don't get hypos from them on their own. And it's not mega expensive for a new diabetes drug. It's about 40 quid a month, which is still quite expensive if you've got 10% of your population with diabetes. The catches with the SGLT2 inhibitors are that you need good renal function for them to work. And if your EGFR is in the 40 to 50 range, you'll get something like a 0.4% reduction in A1C with canagliflozin. So it will drop your A1C, but 0.4% for 40 quid a month isn't grand. And if you're on a loop diuretic, because you're peeing out sugar and salt as a slight diuretic-like effect, you're not meant to mix them with a diuretic. But on the other hand, if you have someone with high blood pressure and swollen ankles, then the SGLT2 blockers are quite handy. You'll get one episode, or the patient will get one episode of gentle thrush per year. So I generally give them a tube of Canistan. And its license is generally for type 2, but it will probably work in the other varieties of diabetes. So the use of these agents in the elderly, what do we think to this? It is limited. It is limited because of the renal impairment. It's limited because of the use of diuretics. But I would tend to use them if you've got someone on insulin, the weight's a problem, the liraglutide hasn't done the trick, so I'd swap the liraglutide to an SGLT2 inhibitor. Or you've got someone on tablets, they are failing, and you're thinking, should I go for liraglutide? Well, you could try an SGLT2 inhibitor. If you have someone with brittle diabetic control on insulin, you could perhaps drop the dose of insulin to stop the hypos and give them an SGLT2 inhibitor to stop the highs. But the studies for this are discrepant. One study shows that this might work, another study shows it doesn't. But there are options. So it's early days with this class yet. So we've got a type 2 diabetic person failing tablets, and the next question is, do we want to slip a GLP-1 RA like liraglutide, or do we want to slip them insulin? And so if they're skinny or losing weight, then they could have cancer or thyrotoxicosis. But if it's from the diabetes, or it could be from metformin, if it's from the diabetes, they're insulin deficient, and insulin is what they need. There's actually quite a bit of diabetic gastroparesis about, and it's generally not very symptomatic, but if you get someone who tends to throw up and you slip them a GLP-1, then you'll make sure they throw up. So if you've got someone that's always a bit sicky, perhaps not liraglutide for them. And significant renal impairment is a contraindication, but that license for liraglutide is being reviewed at the moment. So significant renal impairment at the moment is a contraindication for the GLP-1s, but that might change. And the real catch with the GLP-1s and kidneys is they probably don't alter the renal function that much, but if you start throwing up, you'll get very dehydrated, and that can upset renal function. And of course, previous pancreatitis is a no-no for the GLP-1s. So the key message for the GLP-1s like liraglutide, exenatide, lixisenatide is they make you throw up. So they're really good tablets, they're really good injections because you lose the weight, drop your blood sugar. It's good as insulin over the first 6 months, but they do make people throw up. So we've gone down the insulin route now, and we've got this person on every single tablet we can think of, and we're going to stick him on some insulin injections. What are we going to do with the tablets? I'd get rid of the pioglitazone because that, with insulin, gives a lot of weight gain and a lot of peripheral edema. And I would check the safety of the other agents and add in keep on the other agents, the other tablets, and add in the insulin. And actually, when it comes to choice of insulin, you can actually do what you like. Whatever you want to do, you will be able to find a paper that will validate your choice. So this is fantastic The main thing I would say is that the fasting hypoglycemia on long-acting basal insulin is one of the main catches. When I'm looking at starting insulin in an older person, one of the main questions I ask is what do they eat, when do they eat, and then the practical consideration of who's going to give it and who's going to test. And if you're going to start someone on insulin, you've really got to have someone testing them to make the full benefit of that treatment. And it's really important to have no fixed ideas, and we end up on whatever does the trick safely. So if someone is eating regular meals throughout the day, 4 meals a day, fine. I'd probably try morning basal insulin. Morning basal Lantus is better than evening basal Lantus, which is better than evening NPH. If they have 1 meal a day, and lots of our folk do have 1 meal a day, then I'd slip them some ready mix like Nova Mix 30 or Humalog Mix 50. And if they're ill in hospital and they really wanted to take control of the sugars, then it's a basal bolus Lantus Nova Rapid regime. And interestingly, when I do that, a lot of them are actually quite happy to go home on the very intense regime, and some of them 10 years later are still on the same stuff. So I think there are at least 70 or 80 different preparations on insulin. So which basal are we going to go for if we're going to go for a basal supplementation? And you could use a good old NPH like Insulatard or Humulin I. It's economical, it's cheap, but it's less predictable than any of the other insulins, and you have to shake it. If you don't shake it 20 times, it won't be mixed properly. So you could look at Lantus or Levemir, the long-acting basal insulins. They're more expensive, but they're more consistent, and they have less chance of hypos, particularly overnight, than NPH. So you're going to go for Levemir or Lantus, and in a Rosenstock RCT, you actually find that people get the same glycemic control and the same A1C, same hypo rate on Lantus and Levemir, but they do that on a bigger dose of Levemir. So Levemir might not be quite as strong as Lantus. So if I've got a frail little old dear, I'd give them Levemir because it's gentle. And if I've got a 200 kilo person, I'd probably just give them a whole penful of Lantus each morning. So that's the basals there. Now there's Degludec. Degludec's come along. It is much, much longer acting. It has fewer hypos. It's better consistency than Lantus and Levemir, but it's much more expensive. So it's what you use when you've tried Lantus and Levemir and you're running into problems. And the problems you might want to try and address with Degludec are if you're getting variable control and you've looked at everything else and you're still getting variable control with hypos on Lantus or Levemir, then Degludec might be a good choice there. And if the timing of your long-acting jab is variable, if it's haphazard, which might be because the patients just are haphazard, but on the other hand, if you have diabetes and you're on Lantus, say, you can't have a lie-in on the Saturday and the Sunday morning because you've got to get up and do your jab. Whereas if you're on Degludec, you can have a lie-in and take your jab at midday. And we've had folk with dementia in one of the care homes. They may or may not let us slug them with the insulin, so slipping them the Degludec when we can has worked very nicely. So we've got them on a basal. We've driven down the fasting, we've got the blood glucose then going up during the day, and we've got several different options. We could accept it, where it's not too bad, they're not thirsty, not peeing a lot, quite bright and chirpy. We could accept that poor control. Or we could spot when the blood sugar goes up, and often goes up over the morning, and we could slip them an injection of quick-acting for breakfast as well as the long-acting. Or you could say, well, we could give them a shot of Novamix, which is quick-acting and long-acting combined. So you could swap your basal to Novamix. Or you could do something else. Well, what else could we do? Well, what Chantal Mathieu did, who's one of my 4 favourite Belgians of all time, was she added either insulin aspart or liraglutide to the basal. And what you find, if you've got someone failing on basal supplementation, is that liraglutide drops the A1C more than adding in quick-acting insulin. You have some hypos, but you have a far lower hypo rate with the liraglutide than the aspart, and you lose weight rather than gaining weight. So if you're failing on a long-acting basal insulin with your type 2 diabetes, adding in liraglutide is a good move.